Bronchiectasis is defined by the presence of permanent dilation, ectasia, of the bronchi. In bronchiectasis, there is also excessive mucus production resulting in reduced airflow. Interestingly, severe infections such as pneumonia and tuberculosis were the predominant causes of bronchiectasis. After the introduction of antibiotics, the thought was that the incidence would decrease. Sadly, this is not the case, and the number of patients with bronchiectasis has risen, placing an increasing burden on global healthcare systems. Recurrent infections cause bronchiectasis, but nearly all diseases affecting the lung can lead to bronchiectasis through different mechanisms. The main clinical significance of bronchiectasis is once it's established, it leads to recurrent airway infections by bacteria and fungi organisms. And then this will obviously cause the chronic cough, sputum production, weight loss, and respiratory compromise. The respiratory tract is important in delivering oxygen from the upper respiratory tract to the lower respiratory tract, which is made up of the trachea, the bronchi, the bronchioles, and finally to the alveoli for gas exchange, where oxygen is exchanged for carbon dioxide. The bronchi are lined by epithelial cells. Let's take a look at the normal defense or protective mechanisms of the respiratory tract. So the epithelium represents a physical barrier built to resist infections through tight cellular junctions. Mucus is produced by goblet cells here to trap bacteria and foreign stuff. The epithelium have the mucociliary apparatus, which sweeps and transports bad things up the respiratory tract into the esophagus, the stomach, to be digested. There are antimicrobial peptides produced such as lysozymes, secretory leukocyte protease inhibitors, defensins, and whatnot to help protect the area from microbes. There's a cough reflex which helps clear things from the lungs, either out of the body or into the stomach, so that it can be destroyed. You also have antibodies, IgA antibodies, which help target pathogens for clearance by the innate immune cells such as the neutrophils and the macrophages. All these mechanisms are thought to contribute and are impaired in bronchiectasis because it increases bacterial colonization in the lungs and susceptibility to infections, the primary pathological hallmark in bronchiectasis. So it has been postulated that there are two distinct phases of disease in bronchiectasis. The first is the insult to the airway epithelium. And this initial insult causes the initial bronchial dilatation and the mucociliary impairment. This initial phase predisposes one to infection and inflammation. First insult will lead to the second phase, which is the ongoing inflammatory cycle and further infections. And because of this, you finally get permanent airway remodeling, the characteristic of bronchiectasis, which is dilatation of the airways with excessive mucus production. So this first insult to the airway epithelium we talked about can be from many causes. So some examples include cystic fibrosis. Cystic fibrosis is a well-known cause of bronchiectasis. It is an autosomal recessive disease caused by mutation in the cystic fibrosis transmembrane conductance regulator gene, or CFTR gene. So the CFTR gene codes for essentially chloride channels, which helps facilitate chloride ions out into the airway lumen. CFTR gene mutation results in thick mucus because water is reabsorbed together with sodium. This thick mucus causes an impaired mucociliary apparatus, increasing the risk of pulmonary infections and persistent inflammation. Another cause of bronchiectasis is airway obstruction, which can be caused by a foreign body being aspirated, an intraluminal obstructing lesion, such as a carcinoid tumor, or an extraluminal cause compressing the airway, such as from a lymph node. Obstruction results in local inflammatory response, causing damage to the endothelium and subsequently mucociliary apparatus dysfunction, increasing the risk of infection and inflammation. Other causes include tracheobronchomalacia or tracheobronchomegaly. These are essentially anatomical defects of the airways. Another cause of bronchiectasis can be any cause of a defective host defense. So impairment in host defenses may be local, such as in ciliary dyskinesia or primary ciliary dyskinesia. On a side note, an example of this could be Cartagener's syndrome, which is a high yield thing to know, which is essentially someone with bronchiectasis or this primary ciliary dyskinesia and sinus invertus. Defective host defenses can be systemic, such as someone who has hypogammaglobulinemia. So this means low immunoglobulins, low antibodies, increasing the risk of infections. Defective host defense can be a result of prolonged immunosuppression, such as a transplant patient. The mechanism of bronchiectasis in patients with defective host defense is likely from bronchial wall injury from repeated infections. Rheumatic and other systemic diseases, such as Sjogren's or SLE, can be complicated by bronchiectasis through the development of interstitial lung disease, the use of immunosuppressive agents, or other unknown mechanisms. Another cause of bronchiectasis is alpha-1 antitrypsin deficiency. So emphysema is the main lung disease recognized in alpha-1 antitrypsin deficiency, but also bronchiectasis. Alpha-1 antitrypsin is a protease inhibitor. It protects the lower airways from damage caused by proteolytic enzymes such as elastase. So as you can imagine, if someone is deficient in alpha-1 antitrypsin, this means that you get more inflammation in the lung. Again, other causes of bronchiectasis include COPD and asthma. Pulmonary infections, so a spectrum of bacterial, myobacterial, atypical bacteria, and viral lung infections have been associated with the development of bronchiectasis. There's something called ABPA, which is allergic bronchopulmonary aspergillosis, which represents a hyperimmune reaction to the aspergillus organism. Rather than a true infection, and is characterized by an exaggerated T helper cell response. Features of ABPA include blood eosinophilia, very high plasma IgE levels, and precipitating and specific antibodies to aspergillus. More rare causes of bronchiectasis include polycystic kidney disease, ataxia telangiectasia, as well as Marfan syndrome. So all these conditions will lead to bronchiectasis and will predispose one to developing recurrent pulmonary infections and inflammation, a vicious cycle. Infection of the lungs triggers inflammation to surrounding lung epithelia. The damaged epithelial cells triggers an inflammatory response. The injured epithelial and tissue macrophages will begin secreting pro-inflammatory cytokines, including interleukin-8, which will recruit more neutrophils, the kamikaze cells. You also have interleukin-1b and TNF-alpha secreted by the macrophages and also surrounding cells, which will recruit more immune cells, including monocytes, and these will cause mucus gland to hypertrophy, as well as cause hypersecretion of mucus. And as we know, hypersecretion of mucus, productive cough, is a hallmark of bronchiectasis. The activated neutrophils will release various proteolytic enzymes such as elastase and metalloproteinases. And this causes surrounding damage to the tissues, causing airway damage, damaging ciliary apparatus, and causing mucus hypersecretion. The damaged airways again create a vulnerable environment for reinfection. Airway neutrophilia is the hallmark of bronchiectasis, although up to 1/4, 1/3 of patients have eosinophil dominant airway inflammation. And this may reflect the different triggers of bronchiectasis. So an infection will favor neutrophils, and allergies and the environment factors will favor eosinophilia being present. The damaged bronchi increases susceptibility to chronic colonization by certain microorganisms such as Pseudomonas aeruginosa, non-tuberculous mycobacterium, as well as Aspergillus. The bacteria most frequently isolated from airway secretions of patients with bronchiectasis include Haemophilus influenza and Pseudomonas aeruginosa. So multiple factors may cause reduced ciliary beating, so disruption in the mucociliary apparatus as mentioned. And again, this can include cyanide produced by the Pseudomonas aeruginosa as well as the neutrophils proteases. The clinical features of bronchiectasis are a cough and the daily production of mucopurulent and tenacious sputum lasting months to years. Less specific complaints include dyspnea, wheezing, and pleuritic chest pain. Hemoptysis can be present from injured vessels secondary to inflammation. Remember, bronchiectasis should be suspected in patients with chronic cough, producing large amounts of sputum. So investigations for bronchiectasis. Now, the diagnosis of bronchiectasis can be made from history of recurrent respiratory infections and also radiological findings. On chest x-ray, findings can include a cystic shadow, thickened bronchial walls called tramlines. However, gold standard of diagnosing bronchiectasis is high-resolution CT chest scan. So here you can see a cystic type pattern of bronchiectasis. At any point in the lung, the internal luminal diameter of the bronchus should be smaller than the external diameter of the adjacent blood vessel. The diagnostic radiological criteria for bronchiectasis is therefore when the airway diameter is greater than that of its accompanying vessel and lack of distal airway tapering. A bronchoarterial ratio of greater than 1 is pathological. Some say, you need a high-res CT chest findings plus airway neutrophilia to diagnose bronchiectasis. Further, on the CT chest, bronchiectasis can be categorized into 3 types based on its morphology. You have cylindrical bronchiectasis, and you can note the dilatation of the bronchi. You have varicoid bronchiectasis, which is like varicose veins in the legs. And then you have saccular or cystic bronchiectasis, which is very big dilatation of the bronchi. Other investigations include spirometry, which often shows an obstructive pattern. Bronchoscopy to locate site of hemoptysis and exclude obstruction and obtain samples for culture. Can also perform serum immunoglobulins to look for, obviously, one of the causes, hypogammaglobulinemia. In addition to airway inflammation, there's evidence of systemic inflammation associated with increased levels of fibrinogen, a coagulation factor, which has been proposed as an indirect marker of disease severity. One can also perform the cystic fibrosis sweat test if they suspect cystic fibrosis as a cause. Also, other investigations include Aspergillus precipitans, as well as a skin prick test. Treatment for bronchiectasis in general. So firstly, recommending one to stop smoking and have yearly vaccination is recommended. Home oxygen may be required if they meet the criteria. There's also postural drainage, which should be performed twice daily. And this is where one goes into specific postures so that they could drain all this mucopurulent stuff out of their body. Chest physiotherapy may aid sputum output and mucus drainage. Other useful things include breathing techniques, as well as pulmonary rehabilitation for adult patients, as it improves exercise tolerance and health-related quality of life. Antibiotics may also be used in the management of chronic bronchiectasis to eradicate organisms such as Pseudomonas aeruginosa. If someone with bronchiectasis has 3 or more exacerbations a year, one can consider long-term antibiotics. And macrolides are the class of oral antibiotics of choice because they have both anti-inflammatory and immunomodulatory properties. So this includes azithromycin, essentially as first line. Inhaled bronchodilators such as nebulized salbutamol may be useful in patients with asthma, COPD, and ABPA. Inhaled steroids are not recommended. Surgical resection of bronchiectatic lungs or lobectomy is indicated in certain situations. For example, if one has bleeding in the lungs, so pulmonary hemorrhage, or the bronchus is just not viable, it's just damaged. So this is the general treatment of people who have bronchiectasis, but then you have treatment if someone has an exacerbation of their bronchiectasis. And really, if someone has exacerbation of their bronchiectasis, the treatment is guided by sputum cultures and sensitivities. Empirical antibiotic therapy is recommended and may be based on previous culture data until the result of the current sputum cultures become available. If there's no previous sputum data or anything available, then a fluoroquinolone such as ciprofloxacin can be started to ensure Pseudomonas coverage until sputum culture results are available. And I guess one thing to remember is that one of the side effects of ciprofloxacin is Achilles tendon rupture. There is a large variation in prognosis. So with some patients having mild bronchiectasis for many years and others progressing rapidly with frequent exacerbations and accelerated lung function decline. Now, I want to end this video by talking about 2 diseases that are associated with bronchiectasis. So it can be a potential cause, I guess. The first is yellow nail syndrome. It's a rare disorder characterized by the triad of yellow thickened nails, lymphedema, and respiratory manifestations. Typically, it can be a cough, usually bronchiectasis or pleural effusions. This is seen in about 50% of people, this triad. Treatment includes vitamin E, treating the bronchiectasis, and use of antifungals for the nails.